Hello students, I'm Dr. Manisha Budhiraja, your Madam Faculty for ENT. I know your exam went well and I'm sure you gave your best. That is all that matters, and in fact that is the only thing that is in our hands. So now just relax, just sit back and let us see what the ENT questions of NEET 2025 were that we have recalled. So we could recall a total of 12 questions from ENT. From the ear, we had 3 questions, from the nose, 4, from the pharynx, 2, and from the larynx, 3 questions. So let us quickly see what these questions were. An industrial worker presented with hearing loss. On examination, Renee's test was negative on the left side and positive on the right side. Yes, so what have we decided? That whenever we see the TFT findings, the tuning fork findings, we will immediately write it down. We will not wait to complete reading the question and then write. Yes? Yes, so that is how it should be done. This is the right ear, this is the left ear, the Renee's and the Weber's. Okay, so Renee's was negative on the left side and positive on the right side. So this tells us that in the left ear, what is the DD? Yes, it can be either a conductive hearing loss or a severe sensorineural hearing loss. Okay, and Weber's was lateralized to the left side. So now when the Weber's is towards the left, what is the DD that you have? Yes, it can be left conductive hearing loss. So yes, that matches with the Renee's finding also. So yes, from TFT, we have come to the diagnosis that it can be a left conductive hearing loss. So let us read further. PTA was done with results shown below. Okay, so let us see what is the PTA. This is the right ear. Are you sure? Yes, the color is red. So yes, it is the right ear, and also round. R for round, R for right. So yes, it is the right ear. What is it showing? Yes, this is the air conduction of the right ear. And is it normal? Yes, up to 25 is normal. So yes, air conduction is normal. If air conduction is normal means what is normal? Air conduction is normal. Air conduction is a measure of conductive plus sensorineural pathway. So it indicates that all the conductive as well as the sensorineural pathway in the right ear is normal, which means that right ear in this patient is normal. Let us see the left ear. Yes, so left ear, what we are seeing is that, yes, this is bone conduction. Bone conduction is, tell me, yes, it is normal. Bone conduction normal means what is normal? Sensorineural pathway is normal. And air conduction we can see is defective. Air conduction we know is conductive plus sensorineural. Sensorineural is good here. So where is the defect? Defect is in the conductive pathway. Also, we do not need to do it like this. The moment we see that the bone conduction is normal and there's a AB gap, we know it is a conductive hearing loss. So yes, again, the PTA is telling us that this is a left conductive hearing loss. Yes, so what is asked is choose the most appropriate diagnosis. Okay, so the first choice is right conductive hearing loss. No. Left conductive hearing loss? Yes. Right sensorineural hearing loss? No. Left sensorineural hearing loss? No. So what is the answer? Left conductive hearing loss. Yes. Was that easy? Yes. A 20-year-old presents with recurrent ear discharge and conductive hearing loss of 30 decibel. Which of the following is the management of choice? Okay. So what is asked is the management of a patient who has come with 2 complaints. Yes, discharge and deafness. Recurrent ear discharge with deafness. And what is this tympanic membrane showing? Yes, it is showing a subtotal perforation. So this much is enough to make a diagnosis. Yes, most of the students said that through the perforation, we were not able to see any ossicles, though in this picture, we are able to see anyway, it does not matter. Whenever you are seeing on the past tense a central perforation, be it small, medium, large, or be it subtotal, yes, and the patient has 2 complaints, the hearing loss as well as the discharge, recurrent ear discharge. What is the diagnosis? Yes, it is mucosal otitis media. Yes, safe CSOM. So what is the answer? What will be the management of this patient? Yes, it will be myringoplasty. Okay, so let us see what the choices are. Myringoplasty, yes, it is the management here. Let us see first what the other choices are. MRM. MRM we do for Yes, for squamous otitis media, for unsafe CSOM. So can you tell me any finding here which is suggestive either in the question or in the picture which can tell us that this is not a mucosal otitis media but a squamous otitis media? No, for squamous otitis media, maybe in the question would have been given a foul smelling ear discharge. Yes, or on the tympanic membrane in the pars flaccida area. Yes, maybe you would be seeing granulations, retraction pocket, cholesteatoma flakes, or in the tympanic membrane, especially in the posterior area, you would be able to see a marginal perforation, granulations, or cholesteatoma flakes. Also in the middle ear, maybe whitish cholesteatoma flakes, you were able to see. So if you were able to see all those findings, then you would think that no, this is a squamous otitis media, and then the answer would be MRM. But no, none of these findings are present here. So no, it cannot be MRM. Atticotomy, again, atticotomy means opening the attic to remove the disease. In which condition? Yes, in which condition do we have disease in the attic? In the atticoantral, that is in the squamous otitis media. Yes, in the pars flaccida area, or in the sputum, or in the attic. Yes, so again, atticotomy will be done for squamous otitis media. So no, not here. Exploratory tympanotomy. Yes, what do you understand by exploratory tympanotomy? What's the name telling you? Yes, exploratory means you are exploring the cause of hearing loss in the middle ear, in the tympanic cavity. Exploratory tympanotomy, you are exploring the tympanic cavity for finding out the cause of hearing loss. Yes, so when do we do exploratory tympanotomy? Now listen to this very, very carefully. Yes. So exploratory tympanotomy is done whenever the patient has come to you with hearing loss. Yes. You examine the patient's ear, and what you see is that up till tympanic membrane, everything is appearing good. And the tests are showing you, the Tunifolk test, the Pureton audiometry, all of them are showing you that the patient has a conductive hearing loss. Now tell me, if the patient has a conductive hearing loss and up till tympanic membrane, everything is appearing good, where's the defect? Yes, it means the defect is in the middle ear. But the rest of the tests are not exactly telling you the conclusive diagnosis that yes, this is the defect in the middle ear. So now you know that the defect is in the middle ear, but you're not sure what the defect is. So then you want to explore the middle ear to find out what the defect is. That is what is exploratory tympanotomy. See, how do you do that? Yes, do you make an opening on the tympanic membrane to explore the middle ear? No. What we do is we give an incision on the external auditory canal, and we raise the flap along with the complete tympanic membrane. We raise it, we keep it on one side. It is just like you have raised the curtain completely, you have put it aside, and then you are entering a room. Exactly what we do in stepidotomy. Yes, we raise the tympanomeatal flap on one side, and then we enter the middle ear, we do stepidotomy. So that is how we do exploratory tympanotomy also. Yes, so when you enter the middle ear, if you find any finding, for example, you're finding a lot of tympanosclerotic patches, or you're finding fixation of the malleolar incudal joint, the malleus and the incus, or you are seeing dislocation of the incus and the stapes, incudal stapedial joint, any finding that you're finding that could be the cause of conductive hearing loss, so you correct it there and then. So that is what you do in exploratory tympanotomy. You first explore, find out the defect, find out the cause of the conductive hearing loss, and then you treat it accordingly. So here, the tympanic membrane is showing a perforation, and we know that yes, this patient is of mucosal otitis media. We do not want to explore the cause of hearing loss in this patient. So no, we are not going to do exploratory tympanotomy. Always remember, for exploratory tympanotomy, tympanic membrane has to be two features. Yes, tympanic membrane has to be intact first, and second, patient should have a conductive hearing loss. Is that clear? Okay, so we are coming to the answer that we had in our mind the moment we read the question. Yes, it is laryngoplasty. Now tell me, suppose this patient, in this question, also tympanoplasty was given. What would be the better answer, laryngoplasty or tympanoplasty? Yes, so when both are given, always a better answer is tympanoplasty, because type 1 tympanoplasty is the same as laryngoplasty. Okay, now let me ask you another thing. Do you think in this patient, the ossicular chain is disrupted? Tell me. Yes, The hearing loss is 30 decibel. Can just a perforation of tympanic membrane lead to a 30 decibel hearing loss? Yes, a perforation of tympanic membrane can lead to 10 to 40 decibel hearing loss. Depending upon the size and the site of perforation, the hearing loss will change. Yes, so this quick perforation can lead to a 30 decibel hearing loss. If this patient had ossicular discontinuity also along with a perforation, tell me how much would be the hearing loss? Would it be 30 decibel or would it be 40 decibel? 40 decibel. So if there is perforation along with ossicular discontinuity, hearing loss will be 40 decibel. So no, in this patient, there is no ossicular discontinuity. There is only a subtotal perforation, right? Yes, last year was asked that if this much is the hearing loss, what is the possible condition? I think it was given 50 decibel hearing loss. What is the possible condition in the year? So again, that is what is important, which we need to know. So again, this was quite simple question. And always remember that the moment you read the question, yes, the moment you see the picture, you should have a diagnosis in your mind. Is that clear? Yes, you should not just think on deciding what the answer is while after you are reading the choices. The choices should just confirm most of the time that yes, this is the answer. Because some of the students said that why not exploratory tympanotomy? Why not MRM? I don't understand. What in the question, either in the history or in the picture, tells you that this is not a mucosal otitis media? Is that clear? So the next question, a 45-year-old man with abnormal gait and hearing problems presents with CP, cerebellopontine mass. Histopathological examination demonstrates Antony A, Antony B areas with verrucate bodies. What is the most likely diagnosis? So this is a very, very simple question. Yes, here it is just mentioned that there is a CP angle mass, and because of which the patient was having hearing loss and also the patient was having abnormal gait. Probably it was a very big mass, a very big tumor compressing on the cerebellum, leading to this imbalance, abnormal gait, and because of which it has been removed, and histopathological examination is showing the Antony A, B and verrucate bodies. So what is the diagnosis that is in your mind? Yes, it is acoustic neuroma. Let us see the choices. Schwannoma, glioblastoma, oligodendroglioma, medulloblastoma. Yes, yes, very good. The answer is schwannoma, acoustic neuroma. That is a schwannoma. And in rest of these, we do not see Antony A, Antony B or the verrucate bodies. So that is again a very simple question. A 58-year-old male, known case of diabetes mellitus and hypertension, presents with nasal bleeding. The initial conservative management and nasal packing were not successful to control the bleed. Which of the following arteries should be most importantly ligated to control the bleed? Yes, so what is being asked is, yes, that in epistaxis, which is the first artery to be ligated if the conservative management and nasal packing have not been successful? So do you have the answer in your mind? Yes. Very good. It is sphenopalatine artery. Yes, which is the artery of epistaxis? Be it anterior epistaxis or be it posterior epistaxis? Yes, it is the sphenopalatine artery. So which is the artery to be ligated in anterior as well as in posterior epistaxis? First artery to be ligated? Yes, it is the sphenopalatine artery. And where do you ligate it? Yes, 1 centimeter behind the middle terminate in the sphenopalatine foramen area. So what is the hierarchy of ligation? Yes, sphenopalatine. Next, not stop, then yes, next nearer to the nose is maxillary. Yes, next, not stop, then external carotid. And if following external carotid ligation, the bleeding has not stopped, then which is the artery then because of which the bleeding is occurring? Yes, the anterior ethmoidal. So now let us see the choices. Anterior ethmoidal, posterior ethmoidal, sphenopalatine and superior labial. So what is the answer here? Yes, it is sphenopalatine artery. Now tell me, in which case will you first ligate the anterior ethmoidal artery? Yes, if the following first there has been any injury to any artery leading to bleeding from the nose. Yes, because in first the artery that is injured most commonly is the anterior ethmoidal, and that also results in orbital hematoma. So that there we will ligate the anterior ethmoidal. Otherwise, the hierarchy of ligation is what I've just told you. So yeah, again, this was a repeated question and a very simple question. The next question, a boy sustained a fracture and X-ray was done. The lateral X-ray of the nasal bone shows a nasal bone fracture. Which forceps is used for close reduction of his displaced nasal bone fracture? So we do not even require an X-ray here because it is given in the question that X-ray shows a fracture, and what is asked is that which is the forceps for close reduction of nasal bone fracture. So yes, the X-ray here is showing this is the fracture line. Yes, we know that X-rays are not conclusive, not diagnostic of nasal bone fractures, because the vessels on the X-ray also might appear like fracture lines. So otherwise, sometimes it is very, very clear, very obvious when it is the bones appear totally displaced, but otherwise it might show total displacement, it might not show. So that is why X-ray is not conclusive. So what is the forceps? Let us see the choices. Tilly's forceps, Walsham forceps, Lux forceps, Bayonet forceps. So yes, again, a very easy question. Walsham forceps. So now tell me, Walsham is for the nasal bone or the septum? Yes, for the nasal bone. How did we remember this? Bony wall is Walsham. Yes, and for the septum we have ashes. Ashes. Yes, so can you tell me here which one is Walsham and which one is ashes? 1 or 2, which one is Walsham? Yes, 1 is the Walsham and 2 with longer blades, that is the ashes for the septum. Which of the following statements regarding orbital cellulitis is true? So we have to mark the true statement. Yes. So inflammation is restricted anterior to the orbital septum. What do you think? This is true or false? Yes, when the infection and inflammation is restricted anterior to the orbital septum, as in picture 1, what is that known as? Yes, that is preseptal cellulitis. Whereas in orbital cellulitis, the inflammation is posterior to the orbital septum of the extraocular muscles, of the fat, of the orbital tissues. So this is known as postseptal cellulitis. Yes, so here it is anterior to orbital septum. This is false. Ethmoid sinusitis is the most common source of infection in all age groups. Is that true? Ethmoid sinusitis is the most common source of infection in orbital cellulitis. Yes, yes. In fact, the most common cause of orbital cellulitis is rhinosinusitis. Any of the sinusitis of any of the sinuses can lead to orbital cellulitis. The most common complication of sinusitis is orbital. It is orbital. Yes, so orbital cellulitis is most common complication. But if I ask you that which is the most common sinusitis that leads to orbital cellulitis, yes, it is ethmoidal. So tell me 2 reasons why ethmoidal sinusitis most commonly leads to orbital cellulitis. Yes, because it is separated from the orbit by a thin papery bone. So the extension from the ethmoid to the orbit can be as direct extension through the thin papery bone, which is lamina papyracea. Or both of them have a common venous drainage. So the infection can also be hematogenous. So yes, this here is true that ethmoid sinusitis is the most common source of infection for orbital cellulitis. And here there's another thing added here in all age groups. Is that also true? Yes. Or ethmoid sinusitis most commonly occurs in children, and orbital cellulitis also more commonly occurs in children. But even if it is orbital cellulitis that has occurred in adult, then there also the most common cause will be ethmoid sinusitis. So yes, in all age groups. So both these points are correct here. So this is true. Topical broad spectrum antibiotics are the first line of management. Topical, what do you think? No. Oral or IV? Yes, we will give IV here. So this is false. Patient presents with proptosis, blurring of vision, normal pupillary and ocular movement. What do you think? Proptosis? Yes, so much of inflammation of the extraocular muscles and orbital tissues. Yes, there will be proptosis. Blurring of vision. Yes. What do you think? Ocular movement? Yes, with so much of involvement of the extraocular movements, the extraocular muscles, the movement of the eye will be restricted, and it will also be very painful. So this is false. And also, if there is involvement of the optic nerve, there can be involvement of the pupillary reflex. It can be absent. So this is also false. So here, what is, yes, this is false. So what is the answer here? Yes, the answer here is B. A male child in his second decade presents with a recurrent profuse nasal bleeding in the right nasal cavity and right nasal obstruction. Endoscopy shows a globular mass in the right nasal cavity occupying the posterior corner and nasopharynx. CT shows anterior bowing of the posterior wall of the maxillary sinus. What is the diagnosis? So again, the history itself is telling us the diagnosis that it is a young male, yes, with profuse bleeding, with a vascular nasal mass. That is what we are seeing in endoscopy also. And the CT is showing what sign here? Yes, the antral sign or the Holman-Miller sign. What's the diagnosis? Yes, very good. Angiofibroma. Let us see the choices. So yes, nasopharyngeal angiofibroma, antroconal polyp. Antroconal polyp is a pale mass and it never has bleeding, nor does it have the Holman-Miller sign. Rhinosteroma. Yes, no nasal mass, no vascular mass, no so much of epistaxis, no Holman-Miller sign, no rhinosporidiosis, can have a vascular mass, can have bleeding, but not Holman-Miller sign, not antral sign. Yes, so the answer here is angiofibroma. A patient presented with odynophagia and cervical lymphadenopathy. On examination, ulcerated growth was present on the base of tongue, which was found to be squamous cell carcinoma. What is the most common organism associated? So what is asked is, yes, that is squamous cell carcinoma of the base of tongue, in fact, of the oropharynx, which is the organism that is most commonly associated. So let us see the choices. Human papillomavirus, cytomegalovirus, Epstein-Barr virus, and herpes simplex virus. What is the answer? Yes, it is the human papillomavirus. Yes, in fact, the same question was asked in a different way last year, that which is the high risk variants of strains of human papillomavirus does not lead to which of the following, and the choices were cervical carcinoma, anal carcinoma, and oropharyngeal carcinoma and laryngeal papilloma. So what are the high risk strains of human papillomavirus? Yes, 16 and 18. In oropharyngeal carcinomas, again, both have been implicated. And if we ask that more common here is the 16. So out of the four choices that I gave you, anal, cervical, and oropharyngeal and laryngeal papillomatosis, can you tell me which is not caused by the high risk strain? Not by 16 or 18? Yes, the laryngeal papillomatosis, that is by 6 and 11. Can you tell me any other papilloma of ENT? I'm telling you the hint, it is of the nose, which is caused by low risk variant of human papillomavirus, that is again 6 and 11. Yes, that is inverted papilloma, Ringer's tumor, the most common benign tumor of the nasal cavity. Yes, so we are seeing that up till now, all the questions that I've seen have been a repeated question. Yes, so very, very important from all the important topics. So yes, here it is. The answer is HPV. So what are the other things that we need to know in HPV positive squamous cell carcinoma of the oropharynx? Yes, first, these patients, as compared to HPV negative variant of the squamous cell carcinoma of the oropharynx, the HPV positive are usually young patients. Second, they have a low incidence of smoking as well as alcohol intake. Third, these tumors, the primary is small, whereas the lymph nodes in the neck are excessive. Right? So here it is mentioned cervical lymphadenopathy. Yes, and a very important thing is that usually the HPV positive have a better prognosis than the negative HPV negative squamous cell carcinoma of the oropharynx. So coming to the next question. Following a building collapse, a male patient was brought with copious amount of debris in the mouth. The following procedure was done. Which of the following statement regarding the given procedure is true? So what is asked is true about this procedure. What is this procedure? Yes, very good. Cricothyrotomy. What is the indication of cricothyrotomy? Yes, it is Kiko. can't intubate, can't oxygenate. Is this patient meeting this criteria? Yes, there's a lot of debris in the mouth. Yes, following building collapse this patient has done. Maybe there has come to you. Maybe there is injury to the maxillofacial area also, where you will not be able to either intubate the patient, so much of debris in the mouth, yes, or you will not be able to do a bag and mask ventilation. So yes, this fits into the indication for cricothyrotomy. So what is true about cricothyrotomy is asked. So the first choice, it is used for effective ventilation up to 6 hours. What do you think? Can it give ventilation only up to 6 hours? Or can it give ventilation up till 6 hours? What do you think? Yes, see, the cricothyrotomy can give ventilation for up to 24 to 48 hours. Some books mention it as 24 hours, some books mention it as 48 hours. Yes, so this cricothyrotomy is just a procedure which is done for emergency airway management, and it is a procedure which is done to buy time. And you have stabilized the airway of the patient, and then as early as possible, you have to shift the patient to tracheostomy. You do not have to wait for 24 or 48 hours, but yes, maximum you can wait is up till 24 to 48 hours, right? Now, if that is when you do a good surgical cricothyrotomy. Surgical cricothyrotomy means you are giving the proper incision in the neck, proper incision on the cricothyroid membrane, and you have put a big catheter or a big tube through the cricothyroid membrane. Now, there is another cricothyrotomy which is known as needle cricothyrotomy, where you just pass a needle and over that you pass a guide wire through which you pass a small lumen catheter. So that can sustain respiration only up till the needle one can sustain respiration only up till 30 minutes to 1 hour. Right? So in either case, this is false statement. So this is false. So when you do needle cricothyrotomy, yes, do you know that cricothyrotomy, given an incision on the cricothyroid membrane, can be done only if the patient is above 10 years of age. If it is a child less than 10 years, and if you do the cricothyrotomy, the laryngeal cartilages are very collapsible there. So there are more chances of injury to the laryngeal cartilages, to the adjacent structures, and also there are more chances of subglottic stenosis. So that is why in less than 10 years, a surgical proper cricothyrotomy is not done. It is contraindicated. So in less than 10 years, if at all you have to give emergency airway, then you have to do needle cricothyrotomy. So, and in needle cricothyrotomy, when you're doing needle cricothyrotomy and the upper airway, if it is obstructed, what happens when you're putting a needle? It is a very small lumen. The catheter also that you put here is very small lumen. So the patient can inspire, but during expiration, all the carbon dioxide is not able to come out through that small needle, and above the airway is blocked. So there will be pent up carbon dioxide. Yes, so that is why if we are doing a needle cricothyrotomy, that has to be shifted to tracheostomy as early as 30 minutes to 1 hour. Is that clear? So this is the first is false. The next choice, it is used to measure central venous pressure. No, it is done for emergency airway management. So what do you think? Yes, this is false. Next, it should be followed by tracheostomy. True or false? Yes, this is true. Work of breathing is more than bag and mask ventilation. Tell me this. Is the work of breathing more when we do cricothyrotomy? What do you think? Now, when we are doing cricothyrotomy, we are bypassing the upper airway. So the resistance that is offered by the oral cavity, oropharynx, or the supraglottis, that is gone. So the resistance is less, the work of breathing will be less as compared to bag and mask ventilation. And also, if we are giving the respiration through here or here, will it make a difference in the dead space? Yes, when you're giving the respiration through cricothyrotomy or through tracheostomy, you have reduced the dead space by around 50%. So again, the work of breathing goes down. So work of breathing is more. Is that true? No, that is false. So what is the answer here? Yes, the answer here is it should be, true statement is it should be followed by tracheostomy. A 55-year-old patient comes with hoarseness of voice, difficulty in swallowing, and difficulty in breathing. The patient was diagnosed with cancer and surgical management was done. Post-operative picture is as given below. Which of the following surgery was done on the patient? So this is a ditto repeat question from last year again. So here it is clearly mentioned that this patient has a cancer, yes, of the larynx, because this patient had hoarseness of voice along with difficulty in breathing, difficulty in swallowing. So what was the surgery that was done? So what is this picture telling us? Yes, on the picture we are seeing an opening here. What is this? Yes, this is how a permanent tracheostome looks like. And what is the meaning of permanent tracheostome? Permanent tracheostome means that we have cut the trachea. We have removed the larynx completely from above. So we have done total laryngectomy. And the trachea that is left behind, we have pulled it out and we have sutured it to the skin surface so that the patient will now breathe through that, because the larynx is totally gone now. So this is a permanent tracheostome. Whenever you see a permanent tracheostome, you know that the surgery that has been done is very good. It is total laryngectomy. So let us see the choices. Partial laryngectomy, total laryngectomy, standard tracheostomy, percutaneous tracheostomy. Yes, it is total laryngectomy. In partial laryngectomy, you will never pull out the trachea and suture it to the skin because larynx is still there. Yes, and in tracheostomy, be it standard or percutaneous, you will see the tracheostomy tube here, right? So this is total laryngectomy. A 3-year-old child is brought to the casualty with a history of choking over a peanut. The child suddenly becomes unresponsive. What would you do as the next step of management? So what is asked here is that if the patient has become unresponsive following inhalation of foreign body, here it is peanut, what would be the next step? Yes, will you give this child 5 back slaps? Tell me, in unresponsive patient, will you give back slaps or back blows? No, it is done only if the patient is conscious, patient is not in respiratory distress, patient is able to speak. If it is an adult, you give back blows and you encourage cupping. If it is a child, then you will go for alternating 5 back blows, yes, with 5 chest thrusts. So which means that no, in this patient who has become unresponsive, no, we are not going to do this as the next step. Give abdominal thrust. What do you think? Tell me the other name for abdominal thrust. Abdominal thrust also known as, yes, it is known as Heimlich maneuver. So when do you do Heimlich maneuver? Do you do it in an unresponsive patient, an unconscious patient? No. For Heimlich maneuver to be done, the patient has to be conscious and should have the universal choking sign, which means that patient should not be able to either speak, breathe, or cough, right? So if in an adult, yes, we do Heimlich. Can we do Heimlich in a child also? In a child who is 3 years of age, can you do? As in this patient, we can do Heimlich maneuver, but in a 3-year-old child. But this patient is unresponsive, unconscious. So no, this will not be done. Yes. Now tell me, if this patient was conscious and if this child was less than 1 year, could you still do a Heimlich maneuver? Heimlich maneuver is contraindicated if the child is less than 1 year. In less than 1 year, you go for chest thrust, for sternal thrust. Also, Heimlich maneuver is contraindicated in pregnant and in obese. In all these, you go for chest thrust or for sternal thrust. Sternal thrust. And also, if the patient is unconscious, Heimlich maneuver is not done. So then what is done? That is in this question also. If the patient is unconscious, so here in this child, what will you do? Yes, the patient has become unconscious, you will go for chest compressions. And if what will chest compressions do? It will increase the pressure inside the airway and it might push out the foreign body. If it does not happen, you will follow it up with CPR. Yes, you will follow it up with CPR where you will give 30 chest compressions followed by 2 rescue breaths. And after 30 chest compressions, every time you will have a look at the oral cavity and the oropharynx to look for the foreign body, whether it has got dislodged or not. So if you are able to see the foreign body, then you can go for trying to removing it. You can try to remove it by finger sweep. Always remember that finger sweep has to be done only if the foreign body is visible. If it is not visible, blind finger sweep is contraindicated, it should not be done. Right? So either with the help of your finger, you can sweep it and you can bring it out, or if you are able to see it, but if you feel that you will not be able to bring it out by finger sweep, you can use magical forceps to remove it, right? So which means that the next step will be, yes, chest compressions followed by the CPR. And if by chance following CPR also the foreign body has not got dislodged, then what do you do next? Yes, then you do a direct laryngoscopic examination and you see the larynx. If you are able to see the foreign body above the vocal cord, and if you are able to remove it, you will remove it with the magical forceps. But if you feel that no, you will not be able to remove it, CPR has not worked, then you will give emergency airway management, and that will be by cricothyrotomy. And we also saw in the last question that cricothyrotomy, the proper surgical cricothyrotomy, will be done only if the patient is more than 10 years. If the child is less than 10 years, then you will go for needle cricothyrotomy. Yes, and you will immediately shift the patient for removal of the foreign body. And that was another question recently, that removal of foreign body is done by always by rigid bronchoscopy. Yes. So what is the answer here? No, not. Next step is asked, if the patient is unresponsive, unconscious patient, what will you do? Yes, you will not give back slaps. Heimlich maneuver, no, not in unconscious. Chest compressions, yes. Endotracheal intubation, will you do in this patient when the patient is unresponsive? No, you're not sure where the foreign body is. So if you do endotracheal intubation, if the foreign body is in the supraglottis, it might just go get dislodged inferiorly. So no, endotracheal intubation also you will not do here. Now, since this has been a repeated question, foreign body, so I would like to ask you one question here, that will you at all in foreign body do endotracheal intubation? In which case will you do endotracheal intubation in case of foreign body? Yes, so the initial steps remain the same, right? So if it is not responsive, if it is responsive, we know we will give back blows, we will do Heimlich maneuver, right? Now, if the patient is unresponsive, we will do chest compression, CPR. If it does not benefit, then we will do direct laryngoscopy. And if we are able to see the foreign body in the supraglottis above the vocal cord, we will remove it. Not possible, we will do a cricothyrotomy, right? Now, if we are not able to see the foreign body above the vocal cord, yes, if the foreign body is below the vocal cord, lower down in the trachea, tell me, will a cricothyrotomy help in this patient? No, you have to give immediate airway management, and CPR has not worked. You're not able to see the foreign body, which means that the foreign body is lower down in the trachea. So that is the case where you will do endotracheal intubation. Why will you do that? Yes, so that you are able to push the foreign body through the endotracheal tube. You will push it into the right bronchus. You will purposely do it to push it into the right bronchus, and then you will pull back the endotracheal tube, place it over the carina, and then you will give ventilation so that at least the left lung, the left lung could be ventilated, right? So is that absolutely clear now? How you follow up a foreign body airway? Okay, so here the answer is C. Identify the structure marked with arrow as F. So yes, what is marked as F here? This here is F. So yes, there it was very, very evident that it is the neck area that is being depicted. Though here we can also find that out with a little difficulty. We are seeing the teeth here. Yes, and this is the tracheal lumen. So yes, what is depicted is the neck area. And yes, we can make out that this is not a picture that we have seen commonly. So let us see what the choices are. Piriform sinus, thyroid cartilage, epiglottis, vallicula. So the structure that is marked is lateral. So definitely it cannot be epiglottis. No? And also epiglottis will be a center structure like this. And also vallicula, what do you think? So if this is the neck area, so vallicula will be high up. What is vallicula? Vallicula is the area in between the base of tongue and the epiglottis. Yes? So in between, this is the base of tongue here, base of tongue and epiglottis, this area is the vallicula. So that will be higher up. So what is this? We are left with two choices. Piriform sinus and thyroid cartilage. Can this area, lateral area, be piriform sinus? What do you think? Yes? Yes, where is the piriform sinus? Yes, this area lateral here. Yes, just behind the larynx, we have the hypopharynx. Laterally, where we have the piriform sinus. So, yes, this area can be the piriform sinus. And also, can this be thyroid cartilage? What comes to your mind? Yes, the moment you see this picture, yes, this appearance like this might make you think that this is the thyroid cartilage. But have we ever seen any thyroid cartilage in so many x-rays of the neck appearing like this? We have seen so many x-rays of the neck for croup, for foreign body. Yes, do we ever see a thyroid cartilage like that? See this? This is the normal neck x-ray. So many times we must have seen. Do we ever see the thyroid cartilage like that? No. Okay, so you must be thinking that that is a calcified thyroid cartilage. And what we see most of the time is the x-ray neck of child. Now, this is the x-ray neck, the second picture of an adult. Do you see a thyroid cartilage like that which is calcified? You will never see a calcified thyroid cartilage appearing like this picture. Why? It will never appear like this. Why not? Why? Because the thyroid cartilage, even if it is calcified, it overlaps the vertebral bodies. So it will not be seen as a separate structure. You will see the horizontal line of the thyroid overlapping on the vertebral bodies, right? So that is why whenever we want to see the thyroid, or we want to see the larynx, or we want to see the calcification of the thyroid also, we go for a lateral view neck x-ray. Yes, where you can see the hyoid separately, you can see the thyroid, the cricoids, all that separately. If it is calcified, you will be able to see it clearly only on the lateral view. On the AP view, it will overlap on the vertebral bodies, which is seen separate on the lateral view. Is that clear? So yes, we know that this is not thyroid cartilage. Also, we have never seen a thyroid cartilage like this. So what is this? Yes, this is piriform sinus. And what investigation is this? Yes, this is the barium swallow. Yes, where we are seeing the barium collected in the vallicula here up, and also in the piriform sinus down. Yes, so we have also seen barium swallow so many number of times, but what we have seen in barium swallow is the lateral view. Yes, so barium swallow we know is done to diagnose patients of dysphagia. Yes, to find out whether they have a motility disorder or whether they have any anatomical abnormality because of any tumor. So what we usually see is the lateral view. Here, what is seen is the AP view. So whenever we do barium swallow, we do both lateral as well as the AP view. This is the lateral view of the same patient. Now, if I mark now, yes, you will tell me what is the area that I'm marking in the lateral view. Tell me, what is this one where the collection has occurred? Yes, that is the vallicular area, right? This is the epiglottis. That is the vallicular area. And what is 2 here? Yes, 2 is the piriform fossa. So those were the questions of ENT. And yes, except for the last one, the barium swallow picture, which we have not seen commonly. Yes, most of the questions, rest all the questions were the important topics which have been asked in the recent years. In fact, the same questions have been repeated in the recent years.